Dr. Weber, the 2010 ACCF-AHA guidelines recommend low-dose aspirin, that's 75 to 162 milligrams a day, for the primary prevention of CVD in high-risk patients with diabetes. But it no longer, or they no longer, recommend this in patients with low CVD risk. An antiplatelet agent, clopidogrel, is also recommended for up to 1 year following an ACS. So what I'd like you to do is discuss the strengths and weaknesses of these updated guidelines, speaking to their applicability and utility in clinical practice for the patients that you've encountered.
We've gone through a number of changes in our attitude towards the use of antiplatelet therapy. There was a time just a few years ago when we all bought into the idea that everybody over a certain age, call it 50, some people might have said 55 or 60, even if they'd never had an event, were basically in good health, ought to be on low-dose aspirin as a prophylaxis against having a myocardial infarction or an ischemic stroke. The evidence for that was pretty paltry at best, and some large trials, perhaps not absolutely definitive trials, somehow suggested that yes, there was some benefit in preventing coronary events and perhaps ischemic strokes, but a downside of increasing the likelihood of hemorrhagic strokes. So which did you want to have? So I think wisely, the authorities took a step back and said, no, we're going to use prophylactic aspirin in people who are at high risk, maybe severe multiple risk factors, but much more comfortably even than that, people who've already had an event, someone who's had angina or has had some sort of revascularization procedure or has had a myocardial infarction or a stroke or TIA or peripheral vascular disease. Sure, they need to get good antiplatelet therapy. And I agree completely, because it's based on very strong evidence that anyone who's had a PCI, has actually had a stent put in or some sort of an angioplasty procedure, they should be on 2 antiplatelet drugs for at least a year. Some people would argue it should be longer than a year. Again, we don't have too much evidence, unfortunately, but 2 antiplatelet drugs following a major event seems to make sense, and certainly thereafter at least 1 antiplatelet drug on a permanent basis.
We've been talking about all these new drugs. Let me bring us back to at least the 19th century and talk about a reasonably old one. By the way, it's getting scary to me that Lipitor is an old drug when you talk to the residents.
A generic drug.
Lipitor is just old, which just means that we are, I'm not even going to go there.
Yeah.
But I want to talk about aspirin. And what are the clinical and economic outcomes associated with low-dose aspirin maintenance therapy in high CVD risk patients?
I think there's plenty of studies that have indicated that antiplatelet agents particularly have demonstrated value in reducing cardiovascular events in patients who are at moderate to high CV risk. Men over 50 should be on an baby aspirin a day, basically, as a prevention measure. It's statistically meaningful levels of improvement. Are there risks to aspirin therapy? Yes, but they're small, and I think the benefits outweigh the risk in the vast majority of patients.
It's also cheap.
And it's free, actually. That's one of the things with the Affordable Care Act. One of the mandates is that aspirin has to be covered as a preventive benefit now. So what used to be incredibly inexpensive is now free. What's interesting is it hasn't changed the utilization all that much, going from very inexpensive.
People don't know that, though.
I know.
Remember.
Well, we're going to talk about that going forward. But now, Dr. Calabrese, I want you to discuss the roles of some of the other antiplatelet or anticoagulant agents used in clinical practice. And here comes a word salad for you. Let me see if I can get through them all. There's apixaban, dabigatran, rivaroxaban, prasugrel, ticagrelor, taclopidine. I got through all of them, I think. What patient care and treatment gaps do these agents address? And I'd like you to compare and contrast patient outcomes, economic burden to the conventional drug agents.
Yeah, I mean, clearly
this has been a very busy area in terms of pipeline development, and I think it's an exciting area from a cardiovascular perspective in that these agents together represent a major step forward for us, particularly in the management of conditions like atrial fibrillation. Clearly, with the anticoagulants, the thrombin inhibitor and dabigatran, and the factor Xa inhibitors and rivaroxaban and apixaban, these drugs do bring to bear with them a significant advantage versus what has been the standard of care in warfarin. We all know what the issues are relative to warfarin. These drugs, based on some very large trials, anywhere from 13,000 to 18,000 individuals with atrial fibrillation, non-valvular AFib, these drugs have demonstrated at least comparable ability to decrease stroke and systemic embolism. In some instances, like the Aristotle trial with apixaban actually showed advantages, as did dabigatran at the higher dose. They work quickly. There's a much wider therapeutic window in terms of safety with these products. There's less food interactions, less drug interactions, and there's a major convenience for both the provider and the patient in terms of monitoring with these agents. So, from a patient perspective, from a provider perspective, these drugs have been I think will be a major step forward. Now, warfarin in a lot of patients still will be, a primary mode of therapy. A lot of docs like warfarin because they get to see their patients routinely for the routine monitoring. But we also know that probably 50% of patients who should be on warfarin aren't on warfarin for a variety of different reasons because it's a difficult drug to manage. With the antiplatelets as well, and prasugrel and ticagrelor, again, welcome additions to the armamentarium of our antiplatelet options with aspirin and clopidogrel as the standards coming in here. And we've got data, with these products as well from very large trials, Plato trial with ticagrelor in particular.
I'm so glad.
Yeah, see,
someone else has trouble with names.
Which, again, showed mortality benefits and advantages over the current standard in clopidogrel. So I think there's a lot of promise in this particular area, and I think that that can translate with time as we develop more experience and more data with these products into some fairly significant outcome advantages.
Can I rain on Dr. Calabrese's parade just a little bit?
Sure, please do.
Just a little bit.
Just a little bit. It's just going to be...
You enjoy that, don't you?
Yes, I do. Now, I don't disagree with Davis said. However, I think, we still have a lot of unanswered questions.
Sure.
There's a definite lack, particularly with the newer anticoagulants, agents like apixaban, dabigatran, and rivaroxaban, as to their real-world impact. The studies showed superiority or non-inferiority in many cases for both safety and efficacy endpoints in their studies, but that was a study population, and I'm still struck by the fact that they're saying, well, the time in therapeutic response or range for the Coumadin or warfarin was 65% in these studies. Well, in our real world, in our healthcare system, we achieve 80%, and so if you did the statistical analysis, are these better drugs? They don't have anticoagulant or antidote abilities. Right. So there are risks. I mean, I think it's unclear that with the other antiplatelet agents, the prasugrel and clopidogrel and others, that you actually improve the health outcomes when added to aspirin in someone who doesn't have a stent.
Sure.
So I think these are great agents to have, but many of them are costly. Mm-hmm. And I think we need to have a lot of questions answered before we know really where their place is in care.
All right, so let me give this to you, Dr. Handelsman, to sort of wrap up some of these issues, because we're talking about complicated patients.
Yes.
Patients at very high CVD risk with comorbid conditions, cardiometabolic issues. And you got to have strategies in patients with type 1, patients with type 2 diabetes. So which agents, especially for the management of cardiovascular health and prevention of further cardiovascular disease are preferred over the others in your opinion, and why?
Well, I think that we're looking at a comprehensive approach. So I'm looking at addressing blood pressure, glucose, lipids for starters. And assuming, as we said, lifestyle is obviously part of the discussion. So when it comes to statins today, for me, the majority of people with diabetes, the majority of people with metabolic syndrome by one name or another should be on a statin. I happen to like a statin like rosuvastatin, but I do very well with atorvastatin for the majority of the patients, which I happen to prefer over simvastatin for several reasons. It's more potent, and in combination with other drugs can get patients to better goals, and it has less side effect profile than the others. So I think that in the statin and the lipid arena, generally we are very good. We'll have to see if good drugs for HDL will be good. For blood pressure, I think the majority of us tend to look at ACE or ARBs. I think that ACE is kind of getting a return as the more leading the pack, but ACE or ARBs either would be okay. We've got calcium channel blockers. We can get patients to goal very nicely. Our motto is get to goal safely, whether it's for blood pressure, whether it's for lipids, and definitely for glucose that we're talking right now. So we all agree that metformin would be the first drug, but we have about 20% patients that cannot tolerate metformin or cannot be on metformin, let's say because of kidney disease or whatever. But be it as it may, metformin is the accepted first-line drug. And then it depends where the patients are. DPP-4s are very good, easy to take. You know, some of the patients that say, don't give me the needle, will benefit from a DPP-4. And in addition, the nice thing about incretins, no weight gain, no hypoglycemia, true for GLP-1, true for a DPP-4. The TZDs, now that pioglitazone is become actually generic, we are going to see the surge of it coming back up in treatment. And then we've got a whole host of wonderful insulin that we can use in combination with the basal insulins or short-acting insulins, and they're only getting better. So individualized care, out of those drugs that I said, they will all be used first or second or third, and most times, like we say in blood pressure, you need 2 or 3 drugs in combination to control a blood pressure. You will need 2 or 3 drugs to control diabetes, but you need all of them. And unlike in the past, when I would give you 2 and 3 and 4 drugs, I'll give you 1 of each now, get you somewhat of every area control, and then I will start intensify each area at a time.
And Dr. Calabrese.